I'm Jennifer Waugh with News for Jax. 7 million Americans have a condition known as scoliosis. It's a deformity in the spine that causes a curve. It is treatable, but the earlier it's caught in children, the better the chances of correcting it to avoid surgery and back pain later in life. We know parents probably have a lot of questions about how it's treated and the different options that are available right here in Jacksonville. I sat down with pediatric orthopedic surgeon Dr. Kevin Neal with Nemours Children's Health, who answered those questions and also explains at what age scoliosis becomes most noticeable and who is more prone to developing the condition, girls or boys.
Hi, my name is Kevin Neal. I'm a pediatric orthopedic surgeon at Nemours Children's Health.
Perfect. Okay. Would you explain to me, it seems like it to me, are we seeing more cases of scoliosis that are being corrected with surgery than we have before, or is this just advancements in technology that have allowed it to happen? Would you remind us also, how is it typically first spotted to the point where it then becomes a referral to you?
It most commonly happens in teenagers, and it most commonly happens around the time kids are going through their growth spurt. And usually the spines are straight when they're children, but as they grow really rapidly, we don't know why, but some people's spines will grow to the side instead of growing straight up and down. So this is usually picked up in the early teenage years, around 11, 12, 13, 14, and it's usually picked up either by pediatricians who are doing an examination where they see asymmetry in the spine. For example, one shoulder might look a lot higher than the other. One shoulder blade might look like it sticks out more than the other, or the hips might look uneven because of the curve in the spine. And then they get sent to us to check them with an x-ray.
Does when you go to the pediatrician and the pediatrician has the child kind of bend over, touch their toes, and then looks at, does that still work to identify scoliosis or not really?
Yeah, no, that's the most common way we do it. Sometimes they even use a little device that is very much just like a carpenter's level with a little bubble that measures the angle, and they can put that on the child's spine to see how much asymmetry they have, and then if they have too much, then they refer.
Is this typically genetic?
It is definitely genetic, but we don't understand the genetics very well. So it's very clear to us that it runs in families, but even when it runs in families, we're really bad about identifying who in the family is going to get it and who's going to have a smaller curve and who's going to have a larger curve that needs treatment.
And so you just track them because there is some genetic component to it, or they're aware of it, and so they point it out to the pediatrician, and then you just follow it and then just see kind of what happens?
Yeah, that's exactly right. The main way we screen for it is still that physical examination to see if there's any asymmetry in the back. And having a genetic predisposition might clue you into looking closer for it, but it still doesn't require an x-ray unless we really see something off on the physical exam.
And then I want to make sure I understand you correctly. So when I hear that there's a genetic component to it, you would assume that right away when a child is kind of standing and walking at 2 or 3 as an example, that you would see it, but it's not pronounced then, or it just slowly develops?
It's not definitely what we call a dominant trait, which it means even if you have it, it doesn't necessarily mean that your children are going to have it. Okay. So we're really bad at figuring out exactly who in the family is going to get it when another family member already has it. And that's why we rely on that physical exam to figure it out.
So it could be present, but you don't necessarily see it because the child is so young. It really becomes more pronounced then as they get older and start really growing.
That's right. When they start growing really rapidly, that is the most common time that we pick it up and see it.
Do you see it more, is it more common in boys and girls, or vice versa, or neither?
It's a lot more common in girls, which is another reason that we know there must be some genetic component. So it must have something to do with that extra X chromosome rather than a Y chromosome. And so scoliosis that's really small is very, very common in the population. There's almost nobody with a completely straight spine. We're all just asymmetric creatures. And when you're talking about really small curves, it's about the same in boys and girls. But the curves that get larger and progress and need treatment with braces or surgeries, that's 7 or 8 times more common in girls.
So at what point do you decide this is a brace and or this is surgery?
It depends on two main things, bracing versus surgery. One is how large the curve is, and one is how much growth the child has remaining. So braces are meant to prevent progression of the curves. They don't really make the curves go away necessarily, but we try to stop them from getting to the range where they need surgery. So they're really only effective during that growth spurt while the spine is trying to grow sideways instead of straight up and down. So we look at patients' x-rays and we look at their physical exam and other factors to determine where they are in that growth spurt. Usually we're trying to put a brace on people that have moderate-sized curves that don't need surgery, but they have so much growth remaining that they have the potential to have surgery.
Do you find that when you treat with a brace that you then frequently do not need to then have that patient have surgery?
We wish that it worked 100% of the time, that the braces prevented all surgeries. It turns out that they're about 2/3 effective. So when we brace patients and the patients wear the braces like they're supposed to, we can prevent surgery in 2 out of 3.
Okay, so let's move forward then to the surgery.
Okay, sure.
Okay, so is there a certain degree to which you say, okay, we can't fix this, we need to have surgery? At what point? What's the point where you say that this child needs to have surgery?
You know, so we measure the scoliosis in degrees, and so the degree indicates the angle of the scoliosis and how big it is. And there's no degree where you absolutely have to have surgery. We do surgery when curves reach a point where we know that they're likely to keep progressing throughout your life. So smaller curves won't do that. They'll typically stabilize once you're done growing, and they'll just be what they are. And the good news is that smaller scoliosis, it tends to not cause any medical problems. It doesn't affect the internal organs. It doesn't affect function. So if you have a curve that's not cosmetically too bad, and you can live with it, we don't have to do surgery. But there are some curves that get so big that they will continue to progress throughout life. And we don't know exactly why that it is, but presumably it's just from gravity pressing down on the top of a curve. And so when curves reach 45 or 50 degrees, that effect takes over. And we know that if we don't treat it, the curve is likely to continue getting bigger. So that's when we have a discussion with the family about the option of surgery.
Would you explain then what surgery entails?
So the very basic surgery that we do is called a spine fusion. And what that involves is placing strong metal rods on the back of the spine, which you can see here in a before and an after surgery. And so what we do is, while the patient's asleep, of course, we move the muscles out of the way and we contour rods to make the spine straight, and we attach them to the back of the spine and basically pull the curved spine to the straight rods. We then want everything to become nice and solid, and so we do what's called a fusion. And what that means is that we remove the joints in between the vertebra, and we make the bone rough so it can bleed and heal, and then solid bone will grow in between the rods, and it will become a very strong, stable construct, which will fight gravity in the future and prevent the curve from ever progressing.
Could you kind of show me a little bit what you just described by
Yeah.
pointing on the one on the right?
Yeah, absolutely. So this was the before on the left, but then on the right we see that we've straightened the spine using rods, and these are called anchors in the spine that attach the rods to the spine, and those are actually screws that go into the vertebra bone.
Okay, that said, I think about later in life, and you start having lower back pain and the discs become an issue. Do you not have to worry about that then if you forever have these rods in your back?
It's not that you don't have to worry about, because the bad news is that as we all age, all of our spines wear out. And that actually happens whether or not you have scoliosis, and it happens whether or not you have rods in your back. So we actually like to leave as many normal vertebra and normal discs as we can. So we only fuse the area of the spine where the curves are, and only enough that we can get it straight. So we want to leave as much motion as we can above and below the rods. We know that the discs above and below the rods are going to wear out a little faster than normal, because there's just more pressure on them because the other joints can't move. But that's something that we just find on x-rays or MRIs, and we don't know that it's a clinical problem. meaning that people who have had spine fusions for scoliosis seem to have back pain just a little bit more than the general population, but not bad back pain. So they seem to have back pain that's amenable to usual conservative treatments like rest or stretching or taking some anti-inflammatory medicine, which comes over the counter.
What is the recovery like?
It's better than it used to be. So our patients do have to stay in the hospital, but the stay has gotten much shorter. So we average 2 to 3 days in the hospital. Patients don't get to go home from the hospital until they can do normal daily activities, which means they need to be able to eat and drink and walk and take care of themselves before they leave. And they can do that rather quickly. So we get them out of bed and start moving either the afternoon after surgery or at latest the day after surgery. Most of our patients are teenagers, and they will have to stay out of school for a little while they heal and recover. So it's usually 2 to 4 weeks of being out of school. So patients have to be signed up for a virtual option or a hospital homebound option so they don't miss any of their classwork. And then it takes a little time for the bone to grow between the rods and really solidify. So we give our patients about 3 months off of activities like heavy lifting or sports or gym class before we let them go back, just so that we know that everything is healed and fused and solid and safe.
Do you find that once you straighten the spine that they're taller?
Most patients are. The average is about 1 inch, but some of it depends on how big the curve was before surgery and how flexible the curve is before surgery. So some patients get more than 1 inch.
Are they ever limited in what they can do when it comes to activity as a result of having the surgery?
A little bit, but not as much as people think. So the rods are really solid, and after the bone grows in between the rods, it's even more solid. And so they won't bend. So there are a couple of activities that patients just physically won't be able to do with the rods in their back. So full back bends or back flips is difficult. And curling toward the front, like doing a crunch sit-up, for example, is difficult. Everything else is within reason.
If you did those things, could you somehow pull and cause damage? Is that it? Or they literally physically can't do it because they're not that flexible anymore?
Yeah, it's not a matter of hurting anything. It's just that the rods and the bone that grows between the rods to create the fusion is so strong and solid they physically won't bend.
What are the consequences of not having the surgery?
Yeah, so we're recommending the surgery in patients whose curves are likely to progress and get larger when they get older. As curves progress, most patients who have not had surgery do start to experience more back discomfort. And then the prominence that you can see on the back that brought them to the doctor in the first place can get really, really bad. So scoliosis is not just a curve sideways, but it's also a rotational deformity. And so it makes the ribs and the shoulder blades stick up on the side of the curve. And without treatment, if it keeps progressing, that prominence will continue to get larger and larger and larger and make the back look more hunched. And most teenagers are not okay with that.
Is there a point where someone reaches an age that they're too old to have this procedure?
No, technically it can be done at any age. The problems with doing it later in life are, one, the curve may continue to progress and be a lot larger. And it's hard to get as good a correction when the curves are larger. And the other thing is that our bodies naturally get stiffer as we get older, so you may not get as good a correction for that reason. And the third thing is that we're just generally healthier when we're teenagers. So it's much easier to tolerate the surgery and have a quick recovery while you're younger rather than waiting.
So to our viewer who's watching at home who maybe has a child who has scoliosis and they've just sort of monitored it, not given it a whole lot of thought, is there an age that you would tell them, you know, hey, you really need to have it looked at by now because it's better for us to do the surgery by blah age, you know, than waiting?
Yeah, I think that high school is probably a good marker. Definitely get it checked and make a plan before they graduate.
Okay. Is there anything else that the most common questions that you maybe get from parents that we could address that I didn't ask?
Yeah, well, one thing I would say is just how important it is for us to be able to give parents good advice. And so the main thing that we're trying to do when we're evaluating patients with scoliosis is give you a prediction about the future, is try to decide what's going to happen. And we recently did a study here at Nemours where we looked at the bones in the hand, which have a lot of growth plates and allow us to stage where patients are in their growth spurt versus how big the curves are. And we were able to create a database and follow patients until they were mature to see how much they progressed based on those factors. And so we were really able to get good granular data to make accurate predictions about the risk of patients progressing to the point where they need braces or to the point where they need surgeries.
So explain to me what this is, if you will, specifically like what it's called.
So, this is a scoliosis brace.
Okay.
The other name that it's called in the medical world is a TLSO, which stands for thoracolumbo-sacral orthosis. And this is, it's kind of like a corset that people might be familiar with, but it's made out of a more rigid plastic and then foam on the inside. And they're custom made for patients, and they're molded such that the pads inside the brace will press on the ribs, which will press on the spine, and that will provide some temporary correction of the scoliosis while the patient has the brace on. But what we're trying to do is press in the right places where we can prevent the spine from growing sideways. So these are made to fit individual patients. This is the back of the brace, and it goes on with Velcro straps. And patients can learn to get these on and off themselves. We like patients to wear them as much as possible because obviously braces don't do anything if you're not wearing them. So they take a little getting used to. It's kind of like having a new pair of shoes. But teenagers get used to them and tolerate them really well for the most part. And in many cases, they're very successful at preventing curves from progressing and having surgery.
How much during the day is the typical recommendation, and then for how long do they need to wear them?
Doctors would love it if patients wear their braces all the time because we know that they're more effective the more they're worn. And we know that patients that wear their braces more in general have fewer surgeries. Now we also have to be realistic. So we know patients are going to take them off for bathing or swimming or sports or dancing or other activities, and that's fine. We recommend patients get used to sleeping in them. Those hours count. It's great to sleep in them. And then we recommend that they wear them underneath their clothes during the day as much as they can. We think that there's a good threshold at an average about 18 hours a day. And so that leaves some time for other activities where patients can be out of the brace. But if we can get them to be compliant and wear the brace 18 hours or more, they're much more likely to have a good result.
And then a month, 2 months? How long normally, typically?
It depends on how much more they're going to grow for how long they might be in a brace. So if we're starting at a younger age, they could be in it for a while. So our goal is to prevent the curve from progressing so the patient doesn't have to have surgery, but we have to use the brace the entire time the patient is growing. Girls on average finish growing at about age 14, and boys on average quit growing at about age 16. So the amount of time you're going to wear the brace is dependent on when we put it on you. Now the other endpoint we have to mention, of course, is that the brace works in 2 out of 3 people, but not 3 out of 3 people. So the other endpoint is that if the curve is still getting larger, even though we're trying hard with the brace, we'll discuss other options.
Got it. Okay, good. Do you mind turning it around and opening it for us? We just need that video,
And so the patient would slip into this and put it around the body, and then put the Velcro straps through the little loops there. Sorry, I'm having a little trouble doing that one-handed.
Here, I'll hold it for you.
Hope you can edit that a little bit. And then it'll usually tighten, the brace will tighten down to wherever the patient is on their size, and we'll typically draw little lines the first time the brace is fitted to show them an approximate area to tighten the straps. But realistically, there's no downside to tightening them a little bit more. So that it needs to be comfortable enough to wear, but it can be tight enough that it controls the scoliosis while still being comfortable enough to wear.
Is it conceivable that someone would have to wear it for 6 months or a year?
It is, yeah.
Wow.
It is, and yeah, it depends on when we catch the scoliosis and how much growth the patient has remaining. So sometimes the patients have to wear it for multiple years. And if they have to wear it for multiple years, their body's going to change. So we'll often end up doing a new brace every year to accommodate that change.
Okay, good. Boy, that'd be a lot. It's probably hot too.
It is probably hot in the summertime.
I would think it's like, oh boy.
Yeah.
I think about me and getting my daughter to wear her Invisalign and how difficult that was. Can you imagine that? I mean, geez.
It can be hot in the summertime, so we probably want to stay in the air conditioning as much as possible.
Geez, but for
this little bump on the side of the brace is actually a temperature sensor.
Oh, wow.
We're not using that necessarily just to see how hot the braces get, but we're using it to measure body temperature. So we actually are able to access that, and we have a record of how much patients are wearing the brace.
Oh.
So if you're cheating, we know.
I love it. Okay, good. I also interviewed a local teenager who had spine fusion surgery to correct scoliosis. This is his x-ray. You know, he's a marathon runner. Look for his story right now on our website, newsforjax.com. Just click on the Morning Show tab.